Hi, good morning, everybody. Thank you again for the introduction. And I think the task is a good follow-up to the previous lectures that have happened. And here we are basically going to try and discuss about removing fluids and the and the role of net ultrafiltration. So these are my disclosures. So before we go on to that, we probably need to realize or understand how fluid accumulates. And there has been a revision of this understanding over the last decade or more. And the traditional Starling principle has undergone a bit of a revision of how we understand it. And that has come in because of the recognition that there is an endothelial glycocalyx, which kind of behaves as an impermeable layer between the vascular space and the extravascular space. And just below the endothelial layer is a subendothelial space wherein there is absolutely no protein present. And as a consequence, the oncotic difference is between the endothelial glycocalyx and the subendothelial space, which actually helps to kind of retain the fluid within the vascular compartment. So our traditional paradigm of fluid being filtered through the arteriolar side and being reabsorbed into the venous side of the capillary is not true. And basic function of this endothelium is to retain the fluid within the vasculature. Now the fluid that does pass out through the endothelial matrix and the ultrafiltrate that goes out kind of keeps flushing out the protein or the albumin which grows through the endocytes of the endothelial cells and prevents it from accumulating in the glycocalyx. Now this fluid that is eventually filtered out of the endothelium has to be drained via the lymphatics and into the thoracic duct and into the venous system, and that's how it makes its way out of the interstitium. So as has been discussed earlier by Dr. Prowl, in critical illnesses or in disease states where there is inflammation, there is destruction or disruption of this endothelial glycocalyx, and a consequence of which we lose this gradient for fluid retention in the vascular space, and the capillaries become very leaky. Now when you couple this with the disruption of the extracellular matrix as well, and the kind of expansion of the interstitial space like a sponge, like has been discussed before, there is a lot of fluid that accumulates within the interstitial space. And because the lymphatic drainage is compromised or cannot keep pace with this filtration of fluid, there is ongoing development of edema which can happen. And this edema then can happen into the various organs, and they can have the pathological sequelae of organ dysfunction right from the brain to the kidneys to the lungs to the GI to the intestines. Now this pathological sequelae, when it's looked at clinically, it does have impact or implications in the clinical outcomes of patients. So again, I'm just showing you a very old study, and we have seen a few other studies in the previous in the talks. And what this study by Bouchard showed that whether these patients of AKI required or did not require dialysis, there was a graded increase in their mortality as the amount of fluid overload, which was defined as the percentage fluid balance, cumulative fluid balance compared to their weight, increased over a period of time. The other interesting part of this study that was observed was that we always believe that once we have started patients on dialysis and we start offloading fluid, we are going to bring them out of fluid overload. But that may not necessarily be the case in real life. And what this study showed that the greater number or percentage of days the patients remained in fluid overload when they were receiving dialysis, the mortality was worse. So again, it just highlights to the point that when we are dialyzing these patients or when we are mechanically managing their fluid overload, we have to keep this at the back of the mind. There are other studies. This is an outcome from the renal study that again showed that when compared to survivors, the people who are non-survivors, whether at the outset or in the first 48 hours or later in their course of the ICU, had comparatively more positive fluid balance or fluid accumulation over time. Similarly, there were other studies, there are multi-center studies of 1,800 over patients who had sepsis, and in them a higher cumulative fluid balance at day 3, but not in the first 24 hours of ICU admission, was independently associated with an increase in the hazard of death. And it was in these patients that the requirement for resources in terms of mechanical ventilation, in terms of dialysis support, which was also significantly higher. In addition to increasing in mortality, fluid overload is also associated with major adverse kidney events. And when this study looked at the major adverse kidney events, which they define as at 90 days or within or after 90 days in terms of mortality, dependence on dialysis, or inability to recover their kidney function to less than 50% of the previous or baseline GFR, a fluid overload of more than 10% was associated with a significantly higher major adverse kidney event incidence than in patients who did not have fluid overload. Now, while we focus a lot on fluid overload and their adverse consequences, we also need to understand that the flip side of the coin is also unsafe or has adverse outcomes. And this is a kind of a U-shaped curve of patients with fluid. When they are hypovolemic, they could also have adverse consequences in terms of reduced tissue perfusion from anastomosis leakage, confusions and risk of cardiovascular accidents, renal failure, multi-organ failure. And Dr. Prowl had previously alluded to the RELIEF trial, wherein those patients who did require fluid but were not given adequate fluid in the early part did have poorer outcomes and increased risk of AKI and dialysis requirement. Now, there's another study that actually looked at as compared to patients in euvolemia or neutral fluid balance. This study identified that patients who had positive fluid balance had adverse outcomes both in the short term and in the long term, which was a follow-up of up to 1 year. But patients who are in a negative fluid balance as compared to an even fluid balance, though they had a better or a lower short-term mortality, they had a higher long-term mortality at 1 year. So what these studies or these data do highlight that while we have to be cognizant of positive fluid balance and their adverse outcomes, we cannot let our patients go on the negative side too much as well, and therefore we need to try and maintain their fluid status in a sort of neutral area or a neutral balance. Now, whether we are able to objectively define that balance is a challenge, like has just been brought up by Dr. Srinivas in his study. Now, going back to the phases of fluid therapy, we are all aware of the rescue, optimization, stabilization, and de-escalation phase. And most of the time, it is around the stabilization phase that we are beginning to come to a point where we have to kind of reevaluate our fluid strategy, the fluid status, and if required, we need to offload the fluid that may have been given in the rescue stage and as the patient is recovering, to enhance the removal of this fluid. And to do that, we have various options. Of course, patients who do not develop AKI and have preserved kidney function, there could be a spontaneous evacuation of this fluid. Sometimes we need to aid this pharmacologically, but many times we would need to bring in mechanical fluid removal strategies like isolated ultrafiltration or kidney replacement therapy with ultrafiltration. And seldom we may need to even use a combination of these methods to achieve our fluid balance goal. Now, how do we decide on which methodology to go? Basically, there are a few questions that will help us to address whether this patient requires concomitant management of solute balance, of electrolytes, of acid-base balance, whether this patient is or is not responsive to diuretics. And based on the clinical situation of the patient, their response to diuretic, we would probably have made the decision of whether we are going to persist with pharmacological therapy or probably bring in mechanical fluid removal by various methods. Now, just because we we are going to probably stress more on the role of CKRT and net ultrafiltration in CKRT. It's just again a reminder that this is again from the same study from Bouchard, that where the CKRT was associated with a better fluid control over the 10 days of hospitalization or 10 dialysis days as compared to intermittent dialysis. Now, when we are thinking of fluid removal in this dialysis patient, we have to factor in two things. So though the machine and the patient are connected, despite their connection, they do not talk with each other. So on the machine side, the total fluid that goes into the CKRT machine, which is the dialysate, replacement fluid, and anticoagulation, minus the total fluid that comes out in the effluent, is what will determine the net ultrafiltration that happens during the dialysis therapy. On the patient side, on the other hand, there would be certain obligate or intakes that would happen in terms of IV fluids, medications, blood products, and nutrition, minus the patient outputs in the form of urine output, drains, GI losses, insensible losses, etc. Now, in addition to those patients who are receiving dialysis, the net ultrafiltration during CKRT becomes a component of the patient output. But as you may have surmised already from this, the net ultrafiltration only forms one component of the fluid balance equation in the patient. And a net negative or a fluid balance on the CRT machine may not necessarily mean a net fluid balance in the patient. Right? And therefore, when we are considering patient fluid balance, we have to take all their inputs and all their outputs into account. Now, to achieve this net ultrafiltration, we have essentially two strategies which could be described as the ultrafiltration strategy, wherein we prescribe a certain effluent dose at the outset, which will give us a requisite dialysate or replacement fluid or an anticoagulation dose, and then we vary the UF rate to achieve our fluid goal. And the good side of this is it is easy, that you just need to dial in one rate and you just keep changing that rate. But the flip side happens is your effluent volume keeps changing per hour based on the UF rate that you have keyed in, and which would essentially mean that the dose of dialysis delivered would be different, and the solute control and the solute balance may change with time. The alternate strategy may be a replacement fluid strategy, and what we would do here is we would fix the effluent volume that we want to generate per hour, and we could adjust the UF by reducing or increasing the amount of replacement fluid that we are giving to this patient. And in that case, by changing just the convective composition, whether it's coming with replacement fluid or with ultrafiltration, we are able to achieve the net UF that we want without changing the total effluent volume, and hence without changing or influencing the solute clearance in terms of the effluent dose. Now, as much as we know how to achieve the UF, we now also have increasing understanding of how the ultrafiltration intensity has effects on mortality. So this was a review of about 1,075 patients with fluid overload of greater than 5% body weight, and they looked at the net volume of fluid filtered per day from the initiation of either dialysis, intermittent or continuous, and the end of ICU stay, and adjusted it for the body weight. And what they found in those patients where the ultrafiltration intensity was more than 25 mils per kilogram per day had had the lowest mortality at 1 year as compared to patients who had less intensive fluid removal. But on the other hand, there was another study and this was again looked at from the data of the renal trial, where they looked at the rate of fluid removal, and they essentially had three groups: patients where the fluid removal rate was less than 1.01 mils per kilogram per hour versus 1 to 1.75 versus greater than 1.75 mils per kilogram per hour. And what they found is, on the extremes of less than 1.01 or more than 1.75, the mortality was higher in either of these groups as compared to patients who had a fluid removal rate of between 1.01 to 1.75 milligrams per hour. Right. And there was another study that looked at the same UF ranges, and they looked at the renal recovery rate in these patients. And again, what they found is that about 52% of their cohort of the 1,433 patients in the renal study had renal recovery, but every 1 ml per kilogram per hour increase in the rate was associated with a lower probability of kidney recovery. And as you can see here, the recovery rate was maximum for those patients who had a UF intermittent. So what this essentially tells us that we are probably looking like at a J-shaped curve, of how we would offload fluid from these patients. And the safe range or the zone of safety appears to be somewhere in the range of 1.01 to 1.75 mL per kilogram per hour. And there are certain proposals as to why an increased intensity of ultrafiltration may have adverse effects. Because when we increase the ultrafiltration rate, we would probably be affecting the mean arterial pressure, the cardiac output, causing myocardial ischemia, causing myocardial stunning, which would then lead to heart failure. There would be decrease in cerebral blood flow, increase in white matter changes, cognitive decline, and loss of executive function at the cerebral level. And from a kidney perspective, episodes of probably intradialysis, hypotension, or reduced perfusion would promote kidney ischemia and loss of the residual kidney function, landing up with kidney failure and requirement for and dependence on dialysis. And these type of patients with such episodes may also exhibit gut ischemia and endotoxin translocation and sepsis. Right. So again, when we again looked at these and putting all this in perspective, we do have some pros and cons of certain rates of fluid removal, right? So the other thing is how, we know that we can't remove, but we also know that many a times we are setting goals for fluid removals, but we may not be reaching those goals. And this is a study that was just published that looked at the assessment between prescribed and achieved fluid balance during continuous replacement, kidney replacement therapy. And they found, and when they looked at the percentage fluid balance gap, which was the difference between what they targeted to achieve and what they actually achieved, patients with a higher fluid balance gap or fluid balance gap was independently associated with an increased risk of hospital mortality. So therefore then, how do we target fluid balance and safe net ultrafiltration? So this is a proposal that had come from the AKI meeting, wherein they looked at integrated fluid balance. So very often we are looking at fluid balance goals that we achieve, that we define for prolonged periods of time. And though the fluid balance gives us a composite of what happened to the intake and output, it does not tell us anything of how the vascular volume behaved as this fluid balance was being achieved. So it could be that if I targeted a negative 1 liter fluid balance, I could do and somebody taking in 1 liter obligate fluid intake, I could pull out all the 2 liters of fluid in a span of 6 hours and 8 hours and then keep my patient on 0 UF for the rest of the day. Or I could spread these 2 liters evenly out over 24 hours period. And the greater the time difference between our assessment of the fluid status and setting up the fluid goal, the greater would probably be this discrepancy between the changes in the vascular volume and the fluid that is going into the patient and the eventual fluid that is coming out of the patient. So the whole idea of integrated balance was to minimize this time frame as low as possible, so as we can kind of simultaneously remove the fluid or define our fluid balance goal on a minute-to-minute basis if it is possible, and so that the vascular volume does not show swings, and a consequence of that would be we'll probably achieve our target in a more safe manner. The other thing that we could do to enhance safety was personalize our fluid balance strategy. Again, as has been highlighted, the phenotype of patients that we would see in the ICU would be very different. And some patients like heart failure with fluid overload may require a quicker fluid removal, whereas patients with septic shock, we may need to ease into our fluid removal strategy to kind of allow a bit of hemodynamic stability. while we use our clinical tools and assessments to generally decide and guide our fluid balance, our fluid removal targets, we know that many times this may not be true. So is there ways that we can use as our other methods that we can use as adjuncts to our fluid removal strategies, and would that help us? So there are some studies that are coming out that look at the use of bioimpedance vector analysis and pro-BNP, and they measure the BIA and the pro-BNP to kind of get an assessment of what is the composite fluid state of the patient and how is this fluid distributed, whether as a total body fluid or within the intravascular compartment as a consequence of cardiac dysfunction. And that would help us to decide on the strategy of fluid removal or the intensity of fluid removal. There are other, this was again just a randomized trial wherein they randomized 65 patients on a bioimpedance based strategy of fluid removal versus the conventional method of fluid removal, wherein they reassess the fluid balance every 8 hours. And what they found is when they use a bioimpedance methodology to guide the ultrafiltration rate based on certain agreed parameters, there was a lower water content for the lean body mass in the patients in the study group. There was a higher mean UF rate, and there was a higher urinary output in these patients that was studied. And the mortality rate, the length of ICU stay, and ventilation support duration were however similar. The last part that we can do to enhance safety is bring in measures wherein we could try to mitigate the hemodynamic disturbances that could happen with enhanced fluid removal rates. And these are things that we are generally familiar as nephrologists in terms of altering the temperature of the dialysate, the sodium content of the dialysate, adjusting the dose of vasopressors, and adjusting the rolls. And this is just a survey that has happened in Europe, wherein they looked at the various methods of the net fluid removal and how the physicians and the nurses approach fluid removal in the ICU stay, and what were their interventions they did during hemodynamic instability, and what they thought were the barriers. And as you can see here, for most part, the intervals of fluid goal assessments were in between 6 to 12 hours. And the thing that happened most frequently in terms of hemodynamic instability was a decrease in the rate of fluid removal. So, and the other last part to remember is it's not just the removal. This was a study that looked at fluid intake during the stabilization phase, and there were certain fluids that they categorized as obligatory, which would be vasopressors, sedatives, antibiotics, etc. And some fluids were described as discretionary, which could have been done without or were given on physician advice. And nutrition became a very big part of this. So if there are ways that we could give our nutritional support by minimizing the nutritional volume, it would decrease the total amount of fluid that we would require, and eventually decrease the amount of fluid that we will need to offload for these patients. So with that, I would just like to say that cumulative fluid balance is associated with increased mortality and adverse kidney effects. Mechanical fluid removal should be considered in established fluid overload, high risk of developing fluid overload with electrolyte disturbances or where solute clearances is required. UF or replacement technique may both be used to affect net ultrafiltration. We should aim for a rate of 1 to 1.75 mils per kilogram per hour, which appear to be in the safe range. And we may want to consider using adjuncts to clinical assessment to achieve our fluid balance goals. With that, thank you very much, and I apologize for overrunning.